you for inviting me to the Edwards vote. As you know, for the physicians in the room, whenever there's a CME conference or some disclosures at the beginning, people say, I have nothing to disclose. Well, I have 3 disclaimers to make. First one is the simple one. Yes, Edwards is paying me to be here, so I got to get that out of the way. Second one is that nobody from Edwards told me what to say, and nobody from Edwards told me what not to say. So everything in here is mine. All the opinions are my own. It's not theirs. Third disclaimer is what Dr. Marchand also said. I'm not here to sell you a product. I don't care if you buy a product or not. I'm here to convince you that surgical quality improvement is hard, but it's worth doing, and it really works. And they originally told me I was going to be for an hour. They have me listed for half an hour. So I'm going to talk fast, so put on your seatbelts. Why is surgical quality so hard? What's the usual? Most hospitals do surgical quality by something bad happens. A sentinel event, a death, unexpected, this, that. People get together into a room, talk about what happened, look for the root causes, point some fingers at people, tell somebody they should have done something different. It feels very punitive, very bad. People don't like to be involved.
So that's why this is so hard. Why is it so hard? People, surgeons especially, like habit. A surgeon wants to get into the habit of doing everything the same way every time. Same time, every time, every time, every time, every time. Surgeons don't like to change. Surgeons don't like data. Surgeons don't want to know the data. You ask the average surgeon, what's your wound infection rate? What's their answer? Low. You ask them, what's your hernia recurrence rate? What do they say? Low. Now, the government is going to start getting into this. As you know, these numbers are going to be published by individual surgeons soon. But they're also talking about much more important numbers. Surgical site infection, hernia recurrence, okay. But they're starting to talk about things like, what's your 5-year survival from all the colon cancer operations you've done? Does any surgeon really know that? Does any surgeon really want to know that? Not really. One of my previous chairs used to say, well, that surgeon told me they're very good. And how do you know they're good? They're good because they say they're good. Efficiency. You make change, people lose efficiency. Surgeons don't like to lose efficiency. Time is money. And money. People don't have money to do it. As you know, there are 2 ways we're currently measuring how we do. Everyone's familiar with SCIP. You know SCIP is going to disappear as a core measure. I hope you know, but by 2015, CMS is no longer going to have SCIP as core measures. They're going to take outcomes measures. NSQIP has signed a contract. Any NSQIP hospital, the NSQIP outcomes will be automatically reported to CMS. This will be publicly reported data, and I bet you by 2018 it's going to be physician-specific. So we need to concentrate on outcomes measures. We need to make our outcomes better. What's my background? Why am I here? I went to school at Washington University. I did my training in Strong Memorial Hospital. I spent 15 years at Hopkins, spent 9 years at Greater Baltimore Medical Center. I was associate chair of the department there. I moved in 2008 to Roanoke, Virginia. Now associate professor of surgery, Virginia Tech Carilion School of Medicine, NSQIP surgeon champion, surgical quality officer, associate program director, medical director of OR services. I am now 70% administrative and 70% clinical. You know how that goes. So I still keep an active clinical practice besides wearing all these hats. I'm principally a colorectal surgeon. I'm one of those non-board certified colorectal surgeons. Us old people know that when we graduated, nobody did fellowships. But I've been doing colorectal my whole career. NSQIP. How many of you are from NSQIP hospitals? Some, a smattering. My apologies for those people who are from NSQIP hospitals. I need to run through this quickly because there's a point to going through NSQIP. National Surgical Quality Improvement Program. The history. This actually started in the post-Vietnam era. As the people, again, who are old enough to remember, in the 70s and into the 80s, we treated the returning vets very poorly. And starting in the mid to late 80s, there were congressional hearings. Senator Frank Church held some hearings on the VA system, and they decided that the VA was not treating the vets very well, especially in surgical care. So Congress, in all of its infinite wisdom, passed a law that literally said, the law was big, but this was in the law verbatim. The quality of surgical care at the VA hospitals will be brought up to national standards within 5 years. Noble goal. What's wrong with this? Dr. Shukri Curry led a group.